We have Dr. Mohankumar T for the next topic. He is the president of National College of Chest Physicians. He is visiting professor in India, France, USA and Poland. He has more than 10 orations and 11 lifetime achievement awards, and we are very honored that sir has accepted our invitation on just a single call. Over to you, sir.
First of all, thank you very much for inviting me today. MDR, TB or tuberculosis, all of you, every one of you must be treating that. You may be referring to particular people, and the incidence is on the rise. Government is doing their level best to control the same. When Tushar wanted me to talk about this, I went through the slides of each departments or even the Government of India. There were 413 slides I had. So I had to combine everything together, come down to 20 slides, so that I'll be able to talk before you. The thing is, if postgraduates need that, I have a pen drive I'll give to Tushar, and you can go through that and see that. The structure of the presentation today will be current tuberculosis scenario, Indian estimates, new performance indicators, and also the TB diagnostics, what the WHO says and what others do. A little bit about drug-resistant tuberculosis and about the new guidelines and 2025. I'll be covering all this in a nutshell. If I go through all this, I won't be able to finish off today. And I'll try to reduce it as much as possible. You know the current tuberculosis scenario today, the incident cases will be 10.8 million globally, about 2.8 million, and now it's an increase of 26%. HIV negative deaths about 12,000, 50,000, and 315,000 in India. MDR, drug-resistant tuberculosis, about 110,000 in India. And HIV, TB, 2.9 in India. Tuberculosis elimination, where are we now? We started long, long ago than any other country in the world. We've been doing it extremely well. We started somewhere in 1994 to 2005. It was DOTS strategy, wherein the government commitment was there, case detection through passive case finding. We started standardized the chemotherapy, and all sputum smear positive TB cases were proper case management conditions were done. Did we really achieve the target was the question. After that, in 2006 to 2015, the Stop TB campaign came. And we pursued high quality DOTS expansion and enhancement. Every PSC, everywhere it was highlighted that and we had a massive healthcare system under that. Engage all care providers and also empower people with tuberculosis and communities. And we also enable and promoted research. Then came another change in the scenario. That was from 2016. This goes up to 2035. And It is an integrated patient-centered TB care, bold policies and supportive systems, intensive research and innovation, and we would like to, by 2035, we would like to have less than one TB case per million population. Current TB scenario, you can read this India TB report 2024, which gives that the current scenario in India. And India becomes the first country in the world to develop its own model for estimation tuberculosis burden. And this is the TB incident burden, incidence rate. WHO 210. Indian model estimate would be about 196. And TB mortality, as per WHO estimate, will be 35. For us, it will be 23. Clinical presentations, signs and symptoms, diagnostic investigations. There is a quote from a survivor. At first, I thought that I was the only person who had spent months being misdiagnosed. When I attended my first TB survivor camp or workshop, I learned that unfortunate truth that experience is not unique. There are umpteen people who had mismanaged cases. And the awareness, public participation, and also the care providers and the TB workers should be more and more sensitized to this. When you are talking about the TB diagnostic workshop, uninfected, all these IGRA tests, skin tests, TB progression tests, microbiological tests, all will be negative. TB infection, plus or minus IGRA. Skin tests may be also plus or minus. Incipient tuberculosis, it will be plus or minus allergic. Skin test will be positive or negative. TB progressive test will be. Mainly TB disease, you get everything positive except radiological evidence will be there in the subclinical tuberculosis also. And so, WHO recommended rapid diagnostic tests. This arsenal available for TB diagnosis in 2025. There are umpteen number of tests. One is the moderate complexity automated NAT for detection of tuberculosis and resistance to rifampicin and INH. That's one. Second one is the low complexity automated NATs. This is expert MDR TB. Then high complexity reverse hibernation based NATs. This is done by GenoScholar PSA TB2. And also there are initial tests, diagnosis tests for diagnosis of TB without detection of drug resistance. There are two, LuCam MTBC detection kit and fluorotype MTB detection kit. Mainly what we need for MDR and others are Expert Ultra, which is incorporates two different multi-copy amplification techniques or targets, and has got a large DNA chamber than Expert, MTB RIF. The Expert Ultra has a limitation detection of 16 CFU per ml when compared to the other one, which is about 114. So the Cochrane library gives an analysis of all this. And when you compare with both, the Expert Ultra, it has got a higher sensitivity and lower specificity, than expert MTP-RIF for pulmonary tuberculosis and in subjects with pulmonary tuberculosis. For detection of rifampicin resistance, expert ultra is much better. For a population, remember, everything should be taken with a pinch of salt. Here, for a population of 1,000 people, where 100 of these presenting with symptoms with tuberculosis, expert ultra will miss about 9 cases. And expert MTB-RIF will miss about 15 cases. And the number of people wrongly diagnosed with PTB or tuberculosis will be partly with expert ultra and about 14 with expert MTB-RIF. This is the diagnostic yield, which has been shown by Sharma et al. They have published this in a textbook in JP Brothers, which is a textbook of pulmonary and critical care medicine, in which you can see that within 2 hours you get the result. But the expert MTB-RIF in 2 hours, the pulmonary tuberculosis is about 95 sensitivity, and extrapulmonary tuberculosis will be about 56 to 80. In expert MTB-RF ultra, the sensitivity will be 99. What pulmonary tuberculosis will be about 69 to 96. Specificity is 100% in LPA. Expert MTP-RIF will be about 99 in both specificity. So, if you take up the new drugs or grouping of anti-tuberculosis drugs, you have a group A, which contains levofloxacin, moxifloxacin, bedaquiline, linezolid, etc. They have segregated into group B, which contains clofazimine, cycloserine, teridesolone, etc. And group 3 had been all the drugs which has been available in the market: ethambutol, daldomide, pyrazinamide, imipenem, cilastin, verapamil, everything comes under group C. If you take up the drug-resistant tuberculosis terminology, when you have a clinical specimen, expert MTB-RIF, first line, second line LPA will show that there are mycobacterial tuberculosis detected. Resistance to rifampicin INH will be, and also plus or minus resistant to others, will show that it is called MDR-TB. Resistant to a single drug is a mono drug-resistant tuberculosis. Resistant to more than one drug, but not to rifampicin INH, will be poly-drug-resistant tuberculosis, and you have got drug-sensitive tuberculosis. Pre-MDR-TB and XDR-TB will be there if you call it MDR-TB with resistance to other TB drugs also. But totally drug-resistant tuberculosis, extremely drug-resistant tuberculosis, that nomenclature is no more. The pre-2021 definition of XDR-TB, formulated in 2006, will be MDR-TB to resistant to any fluoroquinolone. At least one of these 3 second-line injectable drugs, caprimycin, kanamycin, amikacin. There are now new definitions, pre-extensively and extensively drug-resistant tuberculosis. This is the new one. Resistant to rifampicin INH, that's MDR-TB. Fluoroquinolone, if there is, it is called pre-XDR-TB. Plus, at least one group of A drugs, bedaquiline or linezolid, it is called XDR-TB. And now the global burden if you take the percentage of previously treated TB cases with MDR-TB, here pre-XDR TB among MDR-TB people will be about 20%, and the percentage XDR TB among MDR-TB will be about 8%. And this is the algorithm for diagnosis of treatment of tuberculosis, which I think most of the tuberculosis, National Tuberculosis Program people will be showing you. And first, all TB patients should go for a NAT, and then see whether it is a rifampicin resistant detection is there or rifampicin resistance is there. If there is rifampicin resistant not detected, you for the drug sensitive TB regimen. And then if H resistance is there in those kind of people, you have to stop the drug sensitive regimen and go to testing again for other testing and for looking at mono or poly drug-resistant tuberculosis. Here, when there is a resistant, rifampicin resistant, you also have to go for other tests. The algorithm for diagnosis and treatment, when there is a rifampicin resistant detected, second specimen tested at a lab, you should look at first line LPA, second line LPA also, and look at other exclusion criteria for shorter regimens. If there is no additional resistance detected or rifampicin INS resistance is detected, look for other tests. Same way, resistance is detected with both CAT-G and A mutation or fluoroquinolone resistance is detected, you look at for a longer oral MDR regimen. This is rifampicin resistance. If not detected, you have to look for LPA and then go for drug-sensitive regimen. And H resistance detected means, again, go for a reflex testing first line or second line, and then see whether they got a mono or poly drug-resistant regimen, and look at additional resistance also. These all regimens, I know that it is confusing. I know that it is difficult for you to just win one or two slides for me to explain the whole gamut of drug resistance and other things. These are the guidelines taken from some of the studies which have been done all over the world, where there is more tuberculosis, but all this has got conditional recommendation. As far as I'm concerned, very low certainty of evidence. The 2022 WHO consolidated guidelines also recommend a 9-month regimen rather than a longer 18-month regimen with MDR or resistant tuberculosis, in which this is also a conditional recommendation, very low certainty of evidence. In patients with confirmed rifampicin susceptible isoniazid resistant tuberculosis, 6-month alt regimen with rifampicin, ethambutol, pyrazinamide, and levofloxacin is recommended. I also think that it is also a conditional recommendation, very low. So to sum up, we have to take with a pinch of salt everything. You have to individualize, treat them individually, see what are the drug resistance they have. there are umpteen number of guidelines. I do agree. I do agree that the government is doing the level best to do things, but as a physician, as a person who is treating tuberculosis, as a person who are in the first line of treating drug tuberculosis, you have to be careful when you... This is the American Thoracic Society guidelines. You can take this. The isoniazid susceptible, rifamycin susceptible tuberculosis in adults, they say isoniazid, rifampicin, pyrocinamide, 300 milligram daily for 17 weeks, 1000 milligram for daily for 17 weeks. And if you do all this, and if you end up with multiple drug resistance, what are you going to be? So, though WHO, IULD, a lot of people are Indian government, now we had something called a 100-day detection program for tuberculosis all over India. Even National College of Chest Physicians were a part of it. Indian Chest Society was a part of it. How far it is going to help is the question. So as physicians, I implore you to go through each one of your patients with tuberculosis, see what can be done individually. Personalized management would be much more relevant in this scenario. If I stand corrected. I didn't tell you any take-home messages because even I am confused. Thank you very much.
Thank you, sir.